All right, so we're going to talk about some IV fluids, and we've talked a lot about IV fluids over the past several days. Kevin spoke a lot about the debate between balanced crystalloids and normal saline when he spoke yesterday. Jim had some words about IV fluids as well. We're going to dive a little bit more deeply into that literature. We'll talk a little bit about the physiologic basis behind why we give fluids and why maybe we should choose a certain type of fluids. When we look at your chapter here, the first four abstracts really discuss the utility of peripheral IVs, and they're really interesting. And the summary of all four of these abstracts is that the overwhelming majority of IVs that are placed in our emergency departments simply never get used again, whether the patient is discharged or whether the patient is admitted to the hospital. And I don't think that's an overwhelming surprise to anybody here. And I think all of us at some point have taken some effort to, put our hands in front of the nurse. This patient doesn't need an IV. It's certainly a place for money to be recouped in your emergency departments. The data would suggest somewhere between 17 and 20% of peripheral IVs go on to be used subsequently. And they use some statistical manipulation to attempt to identify chief complaints and diagnoses that might be at greater risk for having those IV used. The authors postulate, hey, if we identify certain chief complaints that are particularly high utilization of IVs or certain chief complaints that are particularly low utilization of IVs, perhaps we can protocolize this either from the EMS standpoint, from the nursing standpoint, or at some point to say these patients don't need IVs. Now, this is not a new concept, and I know many of us can think back to a few years ago when a certain emergency medicine physician published a lot of information on this and advocated for limiting IV utilization in emergency departments, talked about how he created pathways in his hospital, because I'm sure we've all run into the problem where the hospitalist or the inpatient team says, a patient can't get admitted without an IV, it's a safety issue, right? Which is obviously crap, but it's a thing. But these are provocative articles that talk about the fact that, hey, maybe you don't need to be placing an IV on everybody who walks through your emergency department. In fact, the overwhelming majority of patients who come through the ED simply don't need peripheral venous access, and we can move on from there. What's really interesting was we move into the second question here, which is the great fluid debate. Should we be using normal saline or balanced crystalloid solutions? This is a fascinating topic, really, truly fascinating, one that has really run the gamut over the past several years, and something that there's a ton of literature about, and I think a lot of confusion about, and a lot of differing opinions, all of which are valid. And I think we need to start from a position of, just like before, putting it in the right context. What are we truly talking about? There's some information in this abstract here, and there's some information about why might hyperchloremic solutions be dangerous. And there's a mantra that has emerged in emergency medicine a little bit, and that is there's nothing normal about normal saline, right? Normal saline derived many, many years ago, but in no way matches plasma. It has a sodium and a chloride content of 154 milliequivalents of sodium and chloride, which is obviously way more than our standard plasma volume. So when we talk about why normal saline might be dangerous for a patient, why it might lead to worse outcomes, we need to look at the studies, we need to look at the outcomes, we need to look at how this was studied. But first we should wonder about how could this possibly be the case, right? First it needs to have some amount of face validity. So I'm going to take you on a little bit of a time warp here, back to the first year of medical school, the first year when somebody put up a picture of the juxtaglomerular apparatus and told you to draw the loops of Henle and remember all these things. And if you think way, way back, you remember things like the macula densa and the afferent and the efferent arterioles. And this actually plays a very significant role in why normal saline leads to potentially worse outcomes. So what the macula densa does is it sits there and it monitors the blood concentration, and really what it's looking for is those chloride ions. And this is why hyperchloremic metabolic acidosis might lead to worse outcomes. If you give normal saline, you give normal saline, you give normal saline, you're increasing the plasma concentration of chloride, and the macula densa sits there right next to the kidney and says, I got too much chloride ions here, I must be fluid down, I must be dehydrated because I'm seeing an increased concentration of chloride ions. What it then does, it sends signals to the afferent and the efferent arteriole to clamp down around the kidney, and we get two things. We get decreased blood flow to the kidney, which these abstracts will look at show exactly that, And you also get swelling of the renal cortex within its capsule, and it strangles the kidney a little bit. And that's why there's always been this face validity that normal saline, which really isn't all that normal, might lead to worse outcomes because you're strangling the kidney induced by that macula densa saying, there's these chloride ions here, I must be fluid depleted, I must need more fluid, I must need to hold on to more fluid volume. So when we look at these abstracts here, that's exactly what this tells us. So abstract number 5 is an interesting little study that looks at renal cortical tissue perfusion and mean renal artery flow velocity, and says exactly that. And I wanted to provide a little bit of reason of why it would show that. I don't think there's many people here that are going to look at an abstract and say, whoa, renal artery flow velocity is down, I got to change my practice. But if we can put it in that right context, it makes a lot of sense. And now we have sort of this operational data, we have true patient-oriented or disease-oriented outcome that shows that what we postulated might be the case is actually occurring. And when we move on to study 6 here is when we begin to move into operationalizing this in patients. Does giving balanced crystalloid versus normal saline lead to different outcomes in patients? And this is the SPLIT trial published in JAMA in 2015, really an important trial which began to set off this debate about the use of normal saline versus balanced isotonic solutions in patients presenting to emergency departments and ICUs. And the SPLIT trial was a negative trial. It found no difference in patient-oriented outcomes in whether you got normal saline or balanced crystalloid. And when I say balanced crystalloid, we can sort of use that interchangeably between the sort of synthetic stuff, the plasma light, the Normasol, those sort of things, and the lactated ringers. And while the SPLIT trial was heavily weighted toward using plasma light as its balanced crystalloid, the other trials are more heavily weighted toward using lactated ringers, but they very much can be used as sort of an interchangeable term of balanced crystalloid solutions. So the SPLIT trial found no difference between the administration of balanced crystalloid versus the administration of normal saline. But when you get into the SPLIT trial, there's some important things in there that begin to inform the subsequent trials and probably inform our ongoing practice. So the problem with the SPLIT trial, the overwhelming one, is the total amount of fluid that most of these patients got, which was about 2 liters total, which that's just not enough to impact anything significant in these patients. And what's more is these patients really weren't that sick. And that's sort of a hallmark that we'll find as we look throughout the subsequent trials. Nonetheless, the SPLIT trial was important. Nonetheless, the SPLIT trial sort of prompted this conversation of, hey, we had this face validity that maybe normal saline ain't that great, but when we trialed it to see if it actually ended up doing anything different, it didn't seem. So there's some sort of clinical equipoise right now. Fast forward a few years to abstract number 7. This is the SMART trial. The SMART trial was published at the same time as abstract number 8, which is the SALTED trial. And these 2 trials, I think, really have defined fluid management in emergency medicine and critical care over the past year or so. These were really tremendously done trials, really fantastically done, and there's a lot of information to pull out of them. So abstract number 7, the SMART trial, was a prospective open-label study that was done at Vanderbilt. It's sort of straightforward. They administered saline versus lactated ringers in patients that were admitted to the ICU. Now, some pumps to the brake here is, again, not a lot of patients got a lot of fluid, and not a lot of patients were all that sick, all right? So if we're looking for a signal of benefit of one thing over the other, it simply is going to become harder, and that's something we see in study after study after study. With Jim mentioning, with discussing looking at head injuries in children less than 2 years old, not a lot of children less than 2 years old have head injuries, so it's harder to find signals of benefit with different interventions. When we talk about apneic oxygenation, pre-oxygenation, when we talk about any number of interventions, when there's a low rate of adverse outcomes, it's hard to find benefit. But we did find some signal of benefit in the SMART trial. Their primary outcome was not met, right? So their primary outcome was looking at, I believe, mortality, right? That was the number one thing they wanted to find. Did more people die when they received normal saline versus those who received isotonic crystalloid? And their primary outcome, hospital-free days by day 28, and it was no difference whatsoever. But in their secondary outcome, which was defined as something called a MAKE 30 score, major adverse kidney events in 30 days. They did find a difference. Patients who received isotonic crystalloid had lower rates of MAKE 30, major adverse kidney events in 30 days. There's a lot we need to talk about really quickly there. So why do you use composite outcomes? A composite outcome is bringing together all these different possible things that can happen. We're talking about mortality, discharge from the hospital. Did your creatinine go up? Did you end up on dialysis? And bringing them all together to one composite outcome. There's positives and negatives to composite outcomes. The positive is that you don't need as many patients. I don't need to have a 100,000 patient trial to find these little tiny things that almost never happen. If I take all the possible bad things and put them together, it's going to be easier for me to find a signal of benefit in my intervention. And as somebody who wants to find things that benefit my patients, I appreciate that. The downside is that now it begins to masquerade as if all of those things are the same, as if dying is the same as your creatinine doubling, right? And that's a little bit of a problem, and that's a little bit disingenuous. Nonetheless, that's what we found in this trial, is that administration of lactated ringers led to lower rates of MAKE 30 than administration of normal saline. Now, what drove that composite outcome? When you look, it was mortality. So that's something, right? Alone, mortality didn't have a huge difference, but when you put it into this more complex calculation of composite outcomes, it really drove a difference in this MAKE 30. So what is the takeaway from the SMART trial? Is that at a minimum, lactated ringers isn't worse, and hey, it might be better, and it might lead to lower rates of MAKE 30, major adverse kidney events in 30 days. And then we move on to the next trial, and that's the SALTED trial. This was kind of the same group of investigators, different first author, and it was done at the same time as the SMART trial, but these were patients that didn't end up in the ICU. This was administration of lactated ringers versus normal saline in patients who were admitted to the hospital, but not to the ICU. These were ER patients, and we had a very similar outcome in these patients. So first off, they weren't administered a lot of fluids. Again, 1 to 2 liters on average for these patients. Primary outcome was negative, but secondary outcome of MAKE 30 was positive. What drove that composite outcome in this one? It was an increase in creatinine. So clearly there's a difference there between an increase in creatinine driving the MAKE 30 in the SALTED trial versus an increase in mortality driving the MAKE 30 in the SMART trial. But nonetheless, the signal learned and the lesson learned from the SALTED and the SMART trials is, again, that at a minimum, lactated ringers is not worse than normal saline, and it's probably a bit better in most patients than normal saline, with some giant caveats here. So after I'm a core faculty in a residency program. After these trials came out, it took, I don't know, a day or two before my residents started ordering lactated ringers left and right, thinking that they're practicing this fantastic evidence-based medicine, and then you watch the emergency department sort of implode a little bit, because the nurses are, what the hell is this? Lactated ringers? We don't have it easily available. I got to go get it from some dusty corner of the emergency department. Patient care slowed down. There are all these questions, right? There's certainly some harm if I want to order some fluids on a patient, but I'm going to have to answer 17 questions before this freaking fluid gets into the patient. There's certainly harm if I'm going to have to wait an hour because it needs to be sent down from some obscure out-of-the-way pharmacy because we don't have any bags of lactated ringer left in the ED because the residents now think it's the best thing since sliced bread, right? Right, so this is a problem, right? So there are huge caveats here. So it's not any worse, but it can be worse if you don't operationalize this appropriately. And then there's times when giving lactated ringers to a patient should not be done. There are things that it doesn't interact well with, right? You cannot put certain things together with lactated ringers. It's not incompatible. The two things at the top of my list here, ceftriaxone and blood, those are like my favorite things to give to patients. I give everybody I meet ceftriaxone, I feel like sometimes, and if it doesn't mix with the lactated ringers, we've just found some harm, right? Even if that harm is I need to start another IV, knowing that only 17 to 20% of these IVs are going to be used in the first place, right? So there's some issues here. And what is a big final takeaway from all of this in the general approach to using fluids in patients presenting to your emergency department is, one, most patients don't need fluids, right? They have a mouth and they can take them down. And if you're giving patients fluids just to give them fluids, consider that you may be the only one doing that, and only about 17% of the time is that IV ever going to be used again. Second is, if you're starting a hospital tomorrow, building up from the ground up, and you're going to stock it with fluids, the data is quite clear that the primary fluid you should be stocking with it and operationalizing is probably lactated ringers. Three is that if you cannot, should not, and never should ad hoc start ordering lactated ringers left and right, because while it may not be worse than normal saline, you're going to run into operational challenges. This is absolutely a worthwhile project to take on and say, hey, it looks like from the collected data here that our primary ED fluid should probably be lactated ringers. And if you want to dive into pontification about the macula densa, I support that, right? But what you cannot do is ad hoc fire off orders of lactated ringers left and right, because you're going to run into operational challenges where harm is derived from an attempt to do good, right? So I think that those are important takeaways, and it's informed by this salted, SMART, and split trials. Our next question here that comes up is, what is the optimal fluid choice and rate for sepsis? And now we get into large retrospective cohorts, which gives us a lot of the same information of what we just talked about. And remember, every time we look at these trials, we always find that observational and retrospective and lower quality trials always seem to suggest larger impacts than the randomized control the clinical trials always show. I don't think the answer is that we should wait for randomized controlled clinical trials. I don't think that our practice of medicine should only ever be informed by randomized controlled clinical trials, because if that was the case, I could put a medical student or monkey with access to PubMed to do my job, and I think it's ridiculous that there's some level of what I call statistical snobbery, that if there's not a randomized controlled clinical trial that says I should do something, then I can't do it. I think that's a little ridiculous. I think that we should not practice evidence-based medicine. I think that we should practice evidence-informed medicine, a synthesis of all the current information available with your clinical experience with the patients and your values and that medical degree you fought so hard for. There's a reason you have it, and you don't need a giant randomized controlled clinical trial for every single intervention in the emergency department for a number of reasons. One, most of the time it's simply not feasible because of the amount of time and money involved. I'm running an RCT right now at my shop, and let me tell you how much of a pain in the ass it is and how much money it takes. It's hard to do these things. And if you're waiting for every intervention in your practice to be based off of gigantic, huge, randomized controlled clinical trials, I think you might be doing your patients a little bit of a disservice. And we get a lot of that information from these retrospective studies, which were done years and years and years before the salted, split, and SMART trials. This abstract number 9 was a large propensity-matched retrospective cohort, which showed that there was a dose-dependent improved mortality associated with balanced crystalloid infusion. The same sort of lesson we got from the salted and SMART trials, and that if you had a sort of sober reflection on this study, made a lot of sense, and we could have implemented many, many years ago. Abstract number 10 looks at it in kids, and there's a lot of things that get my blood pressure up. I think one of the biggest things that gets my blood pressure up is when somebody gets up and says kids aren't just small adults. I hate that, right? I think that it's gatekeeping, it's obstructionist, and we've done a randomized controlled clinical trial of 6 billion kids, and it looks like they all become adults. But what we find is the same sort of lesson that we learn in all the others, is that only, these interventions benefit the sickest and those who get the largest amounts of fluids. These kids with pediatric sepsis generally got small amounts of fluids, mainly because they're kids, but also weren't as sick as the sickest of our adults who seemed to benefit from those interventions previously. So while the takeaway from abstract number 10 was no significant difference between balanced crystalloid infusion versus normal saline, I don't think that the answer there is that it means that there's no difference. Again, I think it means the same thing that we learned from all these previous other trials, is that these fluids that are administered are generally benign, but when we get into large volume fluid infusion and when we get into the sickest of the sick, now we begin to see differences. The same lessons that we see again and again in trial after trial. The next question I think is a fascinating one, and I was happy to see it, is what is the evidence for IV fluid in acute pancreatitis? When I was a resident, we would frequently, obviously see pancreatitis routinely, sometimes the patients would come in with their pancreatitis, whether it be due to gallstone pancreatitis, alcoholic pancreatitis, and we are in Arizona, so I guess to throw out to scorpion pancreatitis here. I've never seen it. Anybody ever seen scorpion pancreatitis? We all learned it once upon a time in step 1 that scorpions can cause pancreatitis. I understand it to be one kind of scorpion, and I understand that there's all sorts of scorpions out here in Arizona, so I'll never come back. But when we talk about pancreatitis, it's a fascinating discussion of the administration of fluid. It's also a fascinating discussion of how we approach medicine in general. We all know that the treatment for pancreatitis is they're not allowed to eat and they're supposed to get a ton of fluid, right? Until 5 years ago when we learned that the treatment for pancreatitis is they should eat as quickly as possible, and we should limit his fluids as much as possible. We see this oscillation in the treatment of pancreatitis over time, and the current best approach to pancreatitis is early feeding, right? The current best approach to pancreatitis is rational fluid administration, not the 10, 15, 20 liters they got once upon a time, but nonetheless, our practice of administration of fluid in pancreatitis once upon a time provided a lot of information. And I remember being in residency, I remember medicine residents every time I admitted a pancreatitis saying, you gave lactated ringers, right, because it decreases mortality. And I remember saying, what the hell? Lactated ringers decreases mortality in pancreatitis? I got to jump into this. So I read every study that was published on fluid administration in pancreatitis once upon a time, and they were right. Lactated ringers decreased mortality in patients with pancreatitis in one small observational study of patients who had post-ERCP pancreatitis. Okay, all right, okay. I don't really see a lot of post-ERCP pancreatitis, but it's provocative because, hey, in this one small population of arguably a sick cohort of patients with pancreatitis, lactated ringers seem to lead to better outcomes. So from there, we jumped into the literature on pancreatitis, and it does seem that all things considered, lactated ringers should be the fluid of choice in pancreatitis. And why is that? There is one study from several years ago that looked at all comers with pancreatitis, gallstone pancreatitis, alcoholic pancreatitis, and post-ERCP pancreatitis, and found no difference in patient-oriented outcomes between the administration of saline and lactated ringers. But what did they find? Very consistently decrease in inflammatory markers, lower rates of CRP, lower rates of ESR, and procalcitonin. And that moves us to the first abstract here, which is abstract number 11, a comparison of normal saline versus lactated ringers for patients with mild acute pancreatitis. So before we jump in, this is mild acute pancreatitis. So are we going to find profound differences in these patients? No, right off the bat, because to find profound differences, you gotta use the sickest of the sick, and that's just because we're really good at what we do generally, right? We're not talking about finding penicillin anymore, guys. We're talking about sharpening a very sharp sword as it is. But what did they find in this trial? Is that administration of lactated ringers as compared to normal saline did lead to lower rates of SIRS at 24 hours. Not at 48 hours, not at 72 hours, no profound difference in patient-oriented outcome, but how much can you expect? How much can you really request for a study looking at mild acute pancreatitis? You could probably slap these patients in the face and tell them to leave, and they're all going to do generally okay. But the lesson is continuous and distinct, and this lesson is the same that we've seen in the bevy of literature that's examined the administration of different types of fluids in patients with pancreatitis, is that, again, once again, that normal saline certainly is not worse than lactated ringers, and probably, particularly in the sick, and particularly in those who get large volumes of fluid, it's probably a little bit better. And when you look at abstract number 12, we move on to early aggressive hydration, hastening clinical improvement in mild acute pancreatitis. Again, early aggressive intravenous hydration with lactated ringers hastens clinical improvement in patients with acute pancreatitis. Really important stuff. We move on to abstract number 13 with the next question is, what is the optimal IV fluid choice for diabetic ketoacidosis? The first abstract here, number 13, published in 2018 in the New England Journal of Medicine, really hit home for me because it was yet another paper that suggested, turns out kids probably are a lot like little adults. And this trial examined different rates of fluid and different types of fluid administration in DKA in children and really beat back on this concept that kids are a completely different approach to DKA. And they administered either normal saline or half normal saline to kids with DKA. And what did they find? Well, whether you administered it fast, whether you administered it slow, whether you administered normal saline or half normal saline, all these kids had the same exact outcome. And that was important and that was informative. None of the kids in this trial, nothing that they examined, looked at lactated ringers. But the question of the use of lactated ringers in DKA has become a common and important one recently and something that we should discuss. So when we look at abstract number 14, this was a comparison of the administration of lactated ringers versus normal saline in kids with DKA. And honestly, I found this to be a fascinating discussion because when we talk about the use of lactated ringers in DKA, there's a lot of things to pull out there, right? So when we administer fluid hydration in DKA, we're doing a number of things. The first thing we're doing is obviously we're hydrating up the patient, but one of the downsides to administration of large volumes of normal saline in a patient with DKA is while we begin closing that anion gap metabolic acidosis, we begin causing a non-gapped metabolic acidosis with that hyperchloremic acidosis. And while it has relatively little impact on what we're doing in the ED, there's always been this suggestion that it causes more headaches for the inpatient teams down the road, right? You have the ICU team or the inpatient team that's having to deal with this patient with a prolonged and continued low CO2. By no means a patient-oriented outcome. It's not like they're dying left and right, but perhaps it's keeping them in the ICU longer. Perhaps it's keeping them on their drip longer. Maybe it's keeping them in the ED longer. And when I need to admit my pancreatitis a few days later, I can't because there's some DKA that's been hanging out with a CO2 of 4 because they got 10 liters of normal saline. So this trial examined the use of lactated ringers versus normal saline in children. And this is a place where it's particularly interesting because DKA, like some very few things, there seems to be a significant difference in how children are treated with DKA versus adults. The reason being is that underlying cerebral edema. Everybody has a fear of exacerbating or causing cerebral edema in a resuscitation of a child with DKA. It's terrifying, it's scary, right? And what do we know about cerebral edema and pediatric DKA? One is that if you take every kid who walks into your ED with DKA and MRI them right off the bat, a significant amount of them already have cerebral edema, right? So that's important. Two, the single intervention most associated with worsening of cerebral edema and poor outcomes in a child with DKA, administration of sodium bicarbonate, right? We know that to be the case. So lactated ringers, which has sodium bicarbonate in it, you would think that if there was ever going to be a harm detected with lactated ringers in the administration of DKA, it would be in this study right here. But what did this study find? Better outcomes with the administration of lactated ringers versus normal saline in children with DKA. That's tremendous, and it's very informative. The takeaway from this is, once again, lactated ringers definitely not worse than normal saline and probably better than normal saline for certain severe patients for administration of large volumes of IV fluid. I think that's our end there. So just to sum it up, most patients don't need peripheral IVs. They're probably going to get them before you can even walk into that patient's room or EMS. But if you're an EMS medical director, maybe you're an ED director, or you have some ability to talk about some operationalization of placements of IVs in your emergency department, and maybe even have those conversations with the inpatient teams to eliminate that sort of ridiculous notion that you have to have an IV for safety purposes for admission to the hospital, there's some money to be saved in this setting. When we talk about administration of fluid, it's understanding that there first is face validity and this physiologic underpinning for why normal saline might be worse than lactated ringers. And then when it's operationalized, when it's put into these studies, we see consistent signal that particularly when we talk about large volumes of fluid resuscitation, particularly when we talk about sick patients, that benefit of lactated ringers seems to shine a little bit more. You can't just ad hoc do this left and right. Don't walk into your department tomorrow, start ordering lactated ringers, because you're going to run into operational issues. You're not going to find any freaking lactated ringers. You're going to run into issues given Rocephin for your UTI or trying to give blood for your fluid for your GI bleed or trauma resuscitation, or simply you're going to cause issues. But if you have an operational role or you have the desire to take on a PI project because you all have so much time on your hands, right, consider that lactated ringers really does have this signal toward better outcomes in most patients. If you're resuscitating a patient with acute pancreatitis, data seems pretty clear that lactated ringers certainly does seem to edge out normal saline in most comers. I like to practice that evidence-informed practice, synthesizing the current literature with what we have, not waiting for giant RCTs to tell me how to practice. By the same token, I like to practice what I call dad medicine. That, I'm working in the ED and my dad comes in. How am I going to practice medicine? There's the medicine I practice day in and day out, but then there's the, no, we're going to do this as sharp a spear as possible, right? Even if there's a signal of benefit, that's where I'm going because we're talking about my family member here and I've synthesized the literature and I want to do what's absolute best for my patient right now. Listen, dad medicine suggests that lactated ringers leads to better outcomes, not just for most patients, but particularly for those patients with acute pancreatitis. And that's all I have. Questions? Thanks, guys.